This week on the BackTable podcast.
Based on the physical exam, I pretty much know, and like Ari, we've done this a long time, and we've done thousands and thousands of these cases. We can pretty much tell you exactly where the lesion is and how much it is before we even shoot the angiogram.
It's just using your sixth or maybe seventh sense.
I mean, it is. We can tell you the flow. When you do it this much, it's almost scary that you're like, wow, I hit that number, right?
Ladies and gentlemen, welcome to the BackTable podcast. If you're a new listener, welcome. For all of our regular listeners, welcome back and thank you for listening. Now a quick word from our sponsor.
FlexVP is a novel innovation that brings a new level of precision and control to dialysis access interventional procedures. Flex contributes to the reduction of procedure complications and extends time between dialysis access interventions. As an easy-to-learn product that is seamlessly integrated into the cath lab workflow, Flex is having positive real-world impact beyond the clinical evidence. Flex clinical benefits have been demonstrated in broad patient populations, including historically underserved populations, and contributes to the support of health equity and access for all patients. Learn more at VentureMedGroup.com.
And now back to the show. Omar and Ari, welcome to the show. Ari has been on the show a couple of times, Omar, so we're going to start with the introductions with you. So just tell us who you are, a little bit of training, and then where your practice is right now.
Yeah, my name's Omar Davis. I'm a interventional nephrologist out of Memphis, Tennessee at Bluff City Vascular. I trained in interventional back in 2007, interventional nephrology, with a gentleman that's well known in this space, Gerald Beathard, and Linda Francisco. That was back in 2007, and we opened shortly after, probably December of 2007, December 10th, 2007, we opened our center. And I mean, we started an interventional nephrology practice here in Memphis, and we've been going strong ever since.
OBL situation, ASC?
It's an OBL right now. We're hoping to be an ASC. We have our certificate of need, so hopefully here soon, cross your fingers, everything pans out fine. I'm an interventional nephrologist by trade. I'm also nephrology boarded. So the difference in my practice is I only do interventional nephrology. I don't do any dialysis work or in the hospital nephrology. So I'm 100% dedicated to AV access procedures for my entire career here since 2007.
Man, so you've been doing that for 17 years?
Yes, sir.
All right. Well, we're going to make sure we're going to pick like every part of your brain to get all the nuggets out. Ari, we've had you on the show a couple of times. I got episodes 139 and 292. The great Ari Kramer is back on the show. Ari, for those who haven't heard your old shows, and there's probably not many, everyone's heard of you, but if you could, just give us a little bit of training and background.
Sure. Ari Kramer from Spartanburg Regional Hospital System in Spartanburg, South Carolina. I trained originally as a general surgeon and graduated in 2002. Now, I had the opportunity to meet the illustrious John Ross, who is probably the godfather of AV access. And I went and trained with him for a period of time and realized that our hospital and community was severely lacking in the ability to really care for dialysis patients in a meaningful way. Our care paradigm was quite fractured. We had numerous subspecialists, but no one taking ownership. So we approached our CMO at the time and chief financial officer, and they gave us a 6-month pilot. That was back in 2005. And so we have been steadily performing AV access work as our specialty. I don't do any work outside of dialysis, and we typically are doing anywhere from 1,200 to 1,600 cases per year. And we specialize in access creation, maintenance, salvage, and abandonment cycling, and trying to optimize renal vascular therapies to enhance our patient outcomes. And that's kind of what we've been doing.
Ari, ballpark, like how many, not excluding like creation and abandonment, but like fistulograms and declots, ballpark in a week, how many will you guys do?
So we are averaging, because we're still in the main OR, so we're HOPD. We in the main OR will average anywhere from 35 to 50 cases in a week in the main OR.
All right, Omar, same question. How about you?
We do roughly, I'd say 12 to 14, cases a day on average. Yeah, do the math. And it just depends. Some days you'll be short cases, and the next day you get overwhelmed. And I should have mentioned too, so yeah, we opened similar to the reason Ari opened back in 2007. I did my nephrology training fellowship from 2003 to 2005 here in Memphis. And during that time, that's where we realized how urgent the need for AV access was. All our patients would mostly come to the hospital for any issues, catheter exchanges, AV, angiograms, declots. Stuff that's done now in an outpatient setting was being done in the hospital with a hospital admission. So those patients were, taking up resources when, urgent cases came in or emergencies. Our patients was often get kicked kind of to the side. And they may be in the hospital a week for a catheter exchange or even a declot. So one of the reasons we opened is we knew the need was there to get these patients dedicated care that they deserved and needed, move that out of the hospital so that they could have the resources to do what they needed. But also these patients, we were able to take care of them in a prompt, quick manner, which in the end, it saved the patients time, and it also saved the, the healthcare system, healthcare dollars.
Yeah, I think about like how important that is to not come into the hospital and then your declot keeps getting bumped because, and sometimes reasonably so, because there's a limited number of hospital resources. And if someone gets a dialysis catheter, they can kind of limp along, but it's just so much easier to get to the declots quicker, get the patient out and back like to their normal life. It's just a shame that, a week wait time for a declot, that's awful. So congratulations to both of you. But what I wanted to paint for the audience is we have two operators here who are doing a lot of cases, in short. All right, so what I wanted to start with is basically your algorithm. We'll start with Omar. Basically, Omar, I would just like your algorithm. Like if you're coming up on a fistulogram, like referred for outflow, what you consider outflow symptoms, how you would approach it, and just like walk us through like, a regular case. And you can make it whatever case you want, but something like basically outflow issue, not like a balloon maturation or anything.
So a common case like today would be a patient that's having prolonged bleeding and high venous pressure. So we get a call from the dialysis unit. This patient bled 15, 20 minutes after their procedure. And that's the bleeding I'm talking about is when a patient dialyzes, you have to insert two pretty hefty 15 to 14 gauge needles into the patient's access. And after dialysis, these needles are pulled. And you just like if you had your blood drawn, you'd put a little 4x4 piece of gauze over it and hold light pressure for it to stop bleeding, which usually should occur. Or you would say, what, about 3 to 5 minutes should be normal?
Somewhere in there,
yeah.
Up to 8.
Yeah,
Sure.
Up to 8 minutes. But when you go 20, 30 minutes, an hour, that there's something wrong. And usually that's a sign of increased pressure within the access. And if you have increased pressure in the access, that's going to make it hard for those platelets in the blood clotting process to complete. All right. So we'll get a call. The patient will come into the office. We will do a physical assessment, which requires us looking at the access, laying our hands on it, which usually gives us an indication. It lets us know pretty quick that there's an issue. Some of the findings are the access is pulsatile. And when we say pulsatile, we're talking about the quality of when you palpate the fistula. If it's pulsatile, that means it's just a hard throbbing, just like if you put your finger on your wrist. And once we establish that, we'll take the patient to the back and perform an angiogram.
Does any of your patients, do they get pre-procedure ultrasounds?
Yes, and I should mention that. So we do what's called a flow study. We have an ultrasound machine where we measure the flow in every patient that comes into our center that has an access. The wonderful thing about the outpatient center, just like primary care doctors, we have established patients. So I would say 90% of our patients that come in, 95, are established patients, not new. And we usually have a baseline flow study on them. So let's say their fistula flow at baseline, which is after a procedure where it's normal, the flow should usually be between, we like 600 to 1,200 mLs per minute. And if their baseline is 1,000, and they come in that day 3 months later, let's say 3 months after we did the index procedure, but for prolonged bleeding or high venous pressures, and we get a flow now of 500 mLs per minute, which is half of what it was. That is a sign that the flow is slowed up, usually because there's some sort of outflow obstruction. Just like on a highway, if you have a car wreck and you're trying to get home, that's an outflow obstruction. Pressure, traffic's going to build up, and the flow of the traffic's going to go down. Fistula does the same thing. The flow goes down. And so physical exam, right, the complaint and the volume flow gives us kind of just compiles that data and validates that there's a problem.
Got it. So what I really want to know is, so once you know that there's a problem, you decided that you're going to intervene, you take them to the operating room or the lab, and I kind of want to just like pick your brain about like your algorithm, like how you start from access,
Okay.
like what your venogram looks like, and then like once you see the lesion, like I want to know like everything you're treating with. Okay, go ahead.
So what we do is we take them to the back, right? And based on the physical exam, I pretty much know, and like Ari, we've done this a long time, and we've done thousands and thousands of these cases. We can pretty much tell you exactly where the lesion is and how much it is before we even shoot the angiogram.
Yeah,
It's just,
using your sixth or maybe seventh sense.
I mean, it is. We can tell you the flow. When you do it this much, it's almost scary that you're like, wow, I hit that number, right?
Okay.
I think Ari and I were talking about at a meeting once about, can you guess flow rates before the ultrasound gets it, right? And it's scary. Sometimes I've hit it on the money, which is scary.
I believe this.
And I'm sure Ari's done the same thing. But yeah, so we take them to the back, and we will first get them on the table, and it basically insert a needle to gain access. We'll put a wire in, and then we'll put what's called a sheath into the fistula, which is, I call it kind of like a little manhole. It gives us access to the lumen of the access, the fistula or the graft. All right. We will shoot contrast or dye through that port, which will basically trace the blood flow from the port all the way to the central vessels. And it's like looking at a map. I don't know if Ari, I don't have any images right here with me, but I'm sure we'll pull some up in a little bit.
We'll show some at the end for sure.
Yeah,
for
so
sure.
when you shoot, it's obvious. I mean, I've had high school students come in and, hey, where's the blockage? And they can just point at it. And I mean, you get something that's wide, then it goes that wide. And so once we see the blockage, we identify the lesion. There's two things we can do. Just because we've done this a lot, we can size the vessel just by eyeing it. That's one way we measure. The other way we measure is IVUS, which is intravascular ultrasound. We will basically put this little small catheter up and pull it back through the access, and it will show us the everything within the lumen. You will see the intimal hyperplasia, which is the area of stenosis. You will see the normal vessel, and we will get a measurement of the normal vessel, and then we'll get a measurement of the stenosis. And then that will give us a percentage of that stenosis compared to the normal vessel. And that's how we pick the balloon. We know we need to balloon it, okay?
Are you using IVUS on every patient or?
If I've just done the patient.
Sure. Okay.
Recently, no. If I know the patient well and it doesn't look like there's a change in size, or if there's a discrepancy in what we see, you have to remember that angiograms are two-dimensional, okay? They're not three-dimensional. You can turn the cameras and get different views. So you can miss stenoses that are present at times in difficult cases. But no, we don't use IVUS on every case, but it does help us out. It ensures that we pick the right balloon size, and it also gives us a measurement of the degree of stenosis in the patient. Or sometimes we see that there's thrombus present, things that we need to know that are there that we don't want to send to the lungs. So IVUS is a valuable tool in that sense. So once we pick the balloon size, and this is in my lab, I'm in an OBL setting. If I was in a ASC setting, there's other things that we could do to prep the vessel or the lesion before that. So in an OBL setting, and I'll let Ari will kind of talk about what he can do in the ambulatory surgery center or hospital setting. I will pick a balloon, and we will insert the balloon in right at the area of stenosis and inflate it until we get what we call full effacement. That's where the balloon is completely open, right? There's no kinks in it. The balloon is blown up into a full circle, right? If you're looking at it in cross-section. And then I like to hold my balloons open for about 2 minutes in accesses. Just, we call it scaffolding. And it's kind of like, you go up and you hold it a while. It ensures that any of the intimal hyperplasia or any of the scar tissue is really torn open. And some of the lesions that we deal with, we call them elastic. So they don't just snap or tear open, they kind of stretch. And so the longer you leave that balloon up, the more those fibers are damaged, or that tissue is damaged so that it remains open.
All right. And then balloon pull down, repeat venogram. And
yeah, so we'll deflate the balloon and pull the balloon out. We'll shoot a second shot. And there's a couple things we look for. Number one, we look for just the obvious, right? Did it go from this tiny to back open, right? And then you look at the flow, the general flow rate. So we'll shoot and make sure that blood is flowing very briskly up through that area. And other thing, you just lay your hand on the fistula and the pulse should have gone away. And what a pulse is, when you feel a pulsatile access, what we're talking about is the quality of the pressure that's resonating to your hand, okay? A pulse is indicative of very high resistance, okay? So it's kind of like if you're running into me and I'm standing there, but I weigh, 300 pounds, the moment you hit me and bounce off, that's a pulse, okay? If you run again, you hit me again, you bounce off. But if I get out your way and you run right by me and you just whoosh by me and keep moving freely, that is what we call a thrill. The other way I say it's like kicking a skateboard that's got rusty wheels is a pulse versus kicking a brand new skateboard. As soon as you kick it, it's going to keep rolling, right? So we ensure that the pulse goes away and that it has a thrill and that it's a nice soft fistula. So those are a few of the things we look at as soon as we've angioplastied to ensure that our post result is good. That, do we have good flow? Is it without resistance? Is the lesion open? And then at times we look for it. Did we have any significant damage, like a dissection? That's where the layers, the intimal layers, or between the within the vein have torn, and there's bleeding between them. And then you can also have a rupture, which is where the vessel tears completely through and you have hemorrhage into the tissue. If that occurs, we'll put the balloon back up, hold it for another, couple minutes, let it back down and see if it resolved on its own. I really like in fistulas for these to resolve on their own. There are cases where they don't, and that's where we will look at putting a stent in.
Sure, no doubt. But like you said, best if you can avoid like the no metal left behind approach for a rupture.
Yeah.
Totally agree.
Yeah.
Yes. All right. So same question to Ari. Ari, I want to hear basically your algorithm for, approaching a fistula where you think there is an outflow lesion to address.
Sure enough. I think there's quite a bit of crossover between what Omar said and what we actually do. So first, our office setup is a little bit different. We're in an HOPD, but we have a short tunnel or runway between the office and the OR. So it allows a quick evaluation. So typically we have 2 nurse practitioners that are working in tandem with me in the OR. And when we get a complaint from a dialysis center or the patient, we'll typically come to the office for an evaluation so that we can appropriately triage, because despite our best efforts to have consistent information about what the patient's complaint is, occasionally there's a disconnect. And, we don't want to bring people with sort of the expectation that they're okay or not well, just based on the say-so of the dialysis center. So what we first like to do is get a look in the office setting, and just what Omar said is the clinical evaluation, the history of the complaint, how long has the complaint been surfaced for them, et cetera, how well have they been dialyzing, medications, confounding features, et cetera. And mostly we also will do that same ultrasound. Now, what we've learned about ultrasound is that it's particularly helpphul when we look at the phase of that ultrasound. So it's not that you just get an ultrasound, but is it monophasic, biphasic, or triphasic? And what we like to see is that diastolic peak, at least 40 to 60% of the systolic peak, where you have real good flow through your AV access. As that diastolic peak starts to touch baseline and it inflect negatively, you have increasing stenosis within your AV access circuit. And now oftentimes we like to use the brachial artery as the surrogate for flow through that fistula because it gives us a good baseline for inflow, and it lets us understand what is actually happening with that AV access circuit because you have a uniform tube essentially in which to look at. Whereas when you get into some of these fistula, particularly if they become tortuous, and where you are within the segment of that access from the anastomosis on out towards the outflow of that access, some of those readings can become a little bit challenging and less reliable. So I think a real good baseline ultrasound tells you, number one, do you have a stenosis within the AV access circuit? And that also gives us, as you said, Omar, good flow measurement that we can reflect back on if we have a previous history with that patient. Now, if the clinical exam, corroborates with ultrasound, and it's interesting that the things that we see with ultrasound sometimes don't necessarily translate with fluoro and vice versa. Largely they do, but they're typically synergistic studies where we can kind of anticipate one thing but not see it quite as well with another eye. And a lot of that has to do with where the eye is on the camera, as you're saying, using triplanar view or circumferential views versus not having those in a biplanar view. So the next phase for us would be if the patient in fact has a stenotic lesion, we would determine where is that stenosis because it starts at the heart and ends at the heart. So you can have inflow problems, you can have outflow problems, and then you can have conduit problems. So largely these problems are conduit problems, and when you look at the full body of access, most of those conduit problems tend to be at the juxta-anastomotic region of the AV fistula or in swing segments like the cephalic arch or turn downs and such like this at the wrist, if you're looking at the wrist, et cetera. And then, of course, you can also have, main channel or cannulation zone type issues. But if you're laying your odds in AV access, you can almost identify in a predictable response where you're going to be having trouble. Radiocephalic fistulas tend to have more challenges at the juxta region and that early swing, whereas your upper arm brachiocephalic fistulas, even proximal radial artery fistulas, tend to have difficulties in the cephalic arch. And that's just a product of flow dynamics, and there's a lot of science we can go into if you'd like to, or we can just, we won't belabor the point.
I trust you on this,
right,
Ari.
Right, but in the instance of let's just assuming we have a stenosis in the access circuit, and it really doesn't matter where it is, I like to look at the maturity of that access to determine where I'm actually going to do cannulation. And I think this is really where percutaneous fistulas have really changed the way we approach our access because it's really broadened our approach to being able to treat patients in a minimally invasive way. For example, we may have a new fistula that is not maturing, and the device footprint is such that if you cannulate the fistula itself, you would run risk of having a hematoma that would even shut down the access because the diameter of your sheath is such that it occupies so much luminal gain and that the hematoma and even manual compression would be enough to offset for future development. Or you have radial artery access where you know that the anastomosis is sometimes challenging, but in a traditional approach where we cannulate the fistula proper in a bidirectional way, inflow versus outflow, and we uncover occult lesions, etc., coming around a very acute angle can be somewhat challenging. So what we have found is that distal radial artery cannulation under ultrasound is quite useful. You can either access through the princeps polyps artery coming through into the radial artery proper, or from the very distal radial artery and allowing us to shoot angiogram through the radial artery itself, slipping a wire up into the cephalic vein, or even an upper arm immature brachiocephalic or proximal radial artery cephalic fistula or basilic, whatever the case may be. And that allows us to get a wire in at a much lower risk to that AV access, at which time we can then determine what the appropriate therapy is. Recently, I would say that, and that kind of brings us a little bit, I think, to the meat and potatoes of why we're here today, is I've been really strongly positioning the Flex device, the vessel prep device by VentureMed, and it's a really a fabulous device. And what that device does is allows us to treat stenosis over guide wire prior to actually performing an angioplasty, which is, by all measure, the staple therapy for most AV access maintenance. But what I think is unique about that device and separates itself from other devices that are in the space is the ease of use, the crossing profile, and the continuous 1 atmosphere of pressure that this device has. So polymorphic lesions are easily treated. So I have a video of that device in use that I can show later, and some photos that we can show about what that device looks like. But essentially, if we look at the device in crosswise, it looks like a Mercedes where it has 3 struts that have microblades along the trailing edge of that access device that penetrate 0.25 millimeter outward. And so when the device is deployed with a thumb toggle and trigger, the device will open up, but at 1 atmosphere of pressure. We are working over an 014 or an 018 guide wire. You can isolate the stenosis of interest and then retract the device across the stenosis, re-sleeve, turn 90 degrees, and do 4 sequential passes so that you get 12 slices through that stenotic lesion, which is usually neointimal hyperplasia. Sometimes we have some calcium in there, but largely it's neointimal hyperplasia.
I have a question, like just to set the scene. So like you would pull out the Flex device if like, so you see an outflow stenosis, like you have a cephalic arch stenosis. And so you've shot your fasciogram, you have your stenosis. So you go straight to like an 014 and 018 wire cross. And then once you've crossed, then you're going with the Flex device to 4 passes, 4 scores?
Yes, that's correct. Because
okay.
Yeah, and this is a bit of a change. Now, a lot of the dialogue around that, is what do we know about balloon angioplasty? It's pretty good, but we know that the results are not incredibly durable. On average, when we do intervention on an AV fistula, you're returning 2 times. It's actually 1.9 times per intervention per patient, and that's per year, right? So we know that when we do angioplasty, it's a relatively uncontrolled setting. We're relying on that balloon to rupture that stenosis in a sort of an uncontrolled manner. And we know that, SIR, for example, has said that, there's a 2 to 7% risk of a significant vascular trauma related to these interventions. So if we have an opportunity to prep the vessel prior to performing that balloon angioplasty, we create a much less traumatic situation to the vessel whereby the barotrauma is markedly reduced across the lesion, and subsequently the outcome is much more controlled. So it's a much less inflammatory response. Because you've done these microincisions, it's all the difference, I like to say, between squeezing a banana and peeling the banana.
Yeah.
Right? So that's kind of what we're doing with these vessels.
All right. I have 100 questions.
Yeah.
So some practical, some a little bit more in theory. You shoot your venogram, you're going to intervene, sheath size for the device. Like, what does it accommodate?
So you can work with a 6. I use, a 6 slender, for example. Like I said, we're doing radial artery work. And so 6 slender is perfectly fine. An 018 or an 014 wire is what it'll accommodate.
And go ahead. It's an over the wire device. So you cross, deploy, and then it's unsheathed. So now you have the 3 blades that are unsheathed, and you pull those back, resheath, and then advance, and then cross again, and then rotate 90 degrees, and just repeat that process.
That's correct. So you make a full circle.
Yeah.
Right.
It's 3 blades, right?
Yep. And so it is 6 French. And what's nice is that it's a controlled depth longitudinal microincision through your stenosis, and it's self-sizing, right? So this is what separates it. It took me a minute to wrap my head around how am I different than a cutting balloon?
Right.
Right. And so it's self-sizing with a single 1 atmosphere of pressure, and that's all it has. So it's never greater than that. And so as it goes across, it's just scoring the vessel, not penetrating through the vessel wall at a fixed rate of pressure.
I see. Once you've made your passes, repeat fistulogram, does the lesion actually look any different?
So depending on the chronicity of the lesion, as we know, when we see accesses, we see them in all kinds, flavors, and shapes. And I'm a practical guy. When you look at, a light snow, yeah, you see a big difference with one pass. But if you get one of these northeastern blizzards, like, you're in Canada in the tundra, it can become a little bit more challenging as that cap of new intimal hyperplasia gets greater. Now, the outer diameter of that, the maximum effect is basically 6 to 7 millimeters. Most of us in AV access would be using by the 75 centimeter shaft length.
Okay. And are you using this for all vessels, but all vessels, like central vasculature to peripheral, or which types of lesions, central lesions and also?
So I feel quite comfortable in arterial lesions leading up into the access. Okay, so we certainly have used that to treat those lesions. We'll use it from the anastomosis up to the cephalic arch at the junction with the axillary vein. We do not typically cross into the central venous system with any degree of aggression. Now, off-label for sure. I'm a little bit worried, right? But my ambition is to maintain totally autogenous circuits, and lacerating something in the central venous system is not something that I'm trying to take a controlled situation, which this device does, and then put it in a situation where we would take away the benefit of that. But what I can tell you, though, in the areas referenced, which is the arterial inflow and through the outflow of that AV access circuit, excluding the central venous system, the usual effacement is markedly, the pressure is markedly lower, where we're seeing the bell curve in our cases where we normally have with a high pressure balloon, you're above 20 to 25, sometimes excluding, all the way out to 35 atmospheres of pressure. We're finding that that's not the case. We're finding most of these balloons are effacing at the 10 to 12, so much more approximating nominal, which means our selection of balloons has changed from high pressure balloons to a lower pressure balloon rating, so that you can do more with less. And then interestingly as well, and I don't know if it's because of the reduction in the injury from the controlled bear trauma or just the reduced overall inflammatory cascade, but the durability of these results is much greater than plain balloon on its own. And there are many published papers that are single-arm series observational studies in this particular area that have seen the podium and have already been in print, which I will have on the show notes for you, but have shown just that. And then in instances where you're in a facility with like an ambulatory center where drug-coated balloons, for example, are not available because of pricing gaps and reimbursement, this company has partnered with some significant people to get a pass-through code. And so depending on your site of service, it allows you to get close to, if not in some cases, equal results as you might get with a drug-coated balloon, which really enhances your outcomes, which is a pleasant outcome. And then there have been some additional work that's been done where they're coupling drug-coated balloon and then actually letting that special sauce, if you would, get into those little micro channels that you've created and getting even enhanced results beyond the traditional balloons study outcomes. So it's pretty exciting, and I think for me it's a staple.
So vessel prep with the Flex device and then balloon angioplasty, Is part of your algorithm ever then to move to drug-coated balloons?
Oh, absolutely. And I speak extensively on drug-coated balloons because I think that they are still the high water mark in long-term durable therapy. And I still stand strongly by, the impact AV-DCB in that regard. But in work with Lutonics, that work has been improved. There's been some outstanding results that Dr. John Ross has shown, and I believe Robert Shaverdian in Germany and Hamburg. They have both shown outstanding results using the Lutonics balloon with this particular therapy. So, again, it's agnostic to what you're overlaying. I guess the big opportunity is that if you're in a place where you're like, hey, I don't really know how to improve this outcome. I have a de novo lesion. Do I want to spring for $1,500 or $1,800 for a drug-coated balloon, where sometimes the natural history of a plain balloon angioplasty is actually surprisingly good, where your results they are what they are for you. They're 0 or 100, and we never can tell that. So, an algorithm that we've been tinkering with is, all right, so you have a de novo lesion. Well, let's just do plain balloon angioplasty and determine your natural history. And if the natural history is less than expected, somewhere less than the 6-month mark, which is, I think, is a good baseline, and it's not, 56% patent at that particular time, well, then the patient returns to us, and typically with a similar complaint, and typically the stenosis remanifests itself. I mean, that's the thing. And so what we're able to do then is say, okay, let's overlay a flex, all right? And then you can see the flex. And now to the institution, they're still not being treated, you're not paying the payment price on a high-pressure, ultra non-compliant balloon. You have a lower cost in the balloon charge, and then because the flex has a pass-through code, at least for the next, 2.5 years, that you're getting a reimbursement code for the facility such that that cost is offset. And then you get to enjoy the durable outcome. Now, depending on how that looks, we go back again. Do you get the extra benefit that we expect? Are you getting that 12 to 25% delta above your previous intervention? And if the answer is yes, then I would repeat that intervention when the patient came as an identical intervention because you've exceeded or you're within the acceptable window. If the number decreases, well, then we would do flex plus DCB, and it's DCP of choice. And in my case, it's impact AV-DCB, just data-driven only. So that's typically what our algorithm looks like, and it has served us quite well.
Omar, I want to kick it over to you. So do you have access to the Flex device, like being in the OBL setting?
I have access, and I use quite a few of them on the early market release for the company to test them out, and definitely did like the ease of use of it. But just because we're in OBL, we're in Memphis, I got to remember what MAC I'm in. It used to be Cahaba. It causes for some challenges, right? Because like a lot of devices, when they first hit the market, they're usually targeted. The codes, the reimbursement codes go for hospital, right? HOPD or hospital-based labs. And that's the right way. I mean, you have to work the process. So the OBLs, unfortunately, are kind of the last to see these great advancements, right? The downside to that for the OBLs is like the majority of the patient population is being treated in OBLs, right? That benefit from these wonderful inventions and devices, especially with the Flex device. And unfortunately, just because of pricing, and they have to have a certain price point. This isn't the company trying to be greedy. Like, no, it is a reason that they have to set that for reimbursement. CMS looks at this, and reimbursement's going to be based on the cost intensive of the device, the work it takes to do it. So we understand that. So I haven't been able to use it as much as I would love to, just because I have to be here to take care of my patients. And if we're unable to, if we're spending more money on doing the procedure than we're getting reimbursed, it doesn't, we can't be here for our patients.
Of course. So let me ask you this though. You've had your hands on the device, Omar, and Ari's told us like some like the ways that he uses it. Yeah. Do you use it any different? Is it any differences in how you use it, number of passes, or?
No, not really. I mean, I think Ari and he's dedicated to vascular access, such as myself. And when you've done the number of cases that we've both done, we all find different ways. But yeah, the key is with this device, it's as he's explained, it's 3 blades, right? Kind of, if I can get my 3 fingers right. And it's creating a constant radial outward force, right, of 1 atmosphere. So as you drag it through something this large, if it gets big, it's just going to come out and it's going to keep in nice apposition or contact with the wall. And it's creating micro incisions. You're essentially weakening the intimal hyperplasia, right? You're weakening it so that when you pull a balloon out, it's going to break up easier, right? With less atmosphere. So yeah, the whole point is the more times you take it through, spin it, the more surface area I can get without overkill.
Sure. I get that.
Same as him. Yeah.
So any ways, question for both of you guys, but we'll start with Omar. Any ways where the device is kind of a hindrance, or not a hindrance, but maybe some obstacles you've had to overcome, like, hey, it's best not to unsheath in this position, or, sometimes when I try and resheath and I'm next to a lesion, it gets hung up or it gets stuck in the sheath. I don't know, just anything like that, because there are going to be users out there who are going to have this for the first time, and just anything that you've learned along the way that may help somebody in those growing pains with new devices.
Yeah, I think to me, the learning curve is quick, but it's more so and it happens quick, is getting used to moving it forward, unsheathing, pulling it back, and then resheathing to go back forward, right? And when I say this, it's just, there's just several, are you go do this first, or which one comes first? But as far as devices are concerned, to me, what's so amazing about this product is that it is so easy to use. And I don't see why I can't really find a situation unless it is a very, very tortuous fistula, which in those cases, we have trouble with lots of devices. And because it's over an 018 wire, 018 wires don't do well with severe tortuosity. You can't get enough pressure on them. So if something's severely tortuous, it's going to be hard to get that device through. Now, having said that, and Ari can agree or disagree with this, most super tortuous accesses are very large, and they're going to be bigger than the device is able to handle. But no, I haven't used it near as much as Ari, but when I did use it, it moves. It's pretty. It moves good. I didn't find anywhere where I couldn't use it in the situations that caught me up.
Yeah.
Ari, same question. Any growing pains?
No, I think Omar did it right when he was patting his head and touching his stomach at the same time.
That's right.
Thank you for the description for our audio only listeners.
About, hey, do you pull the trigger or hit the button? No, I think what your point is well taken, Omar, about the 018 and the tracking of a device across that. So in acute angulation, I think it can become a little bit challenging. I've had cases where, for example, if I were in the percutaneous world where we have a reverse perforator, so you actually get a Z, right? So you get a wire across, and it is enough to straighten that perforator out. But when you take the flex in that particular instance, when those blades are open, you're really not at 1 atmosphere. You're at that compression of the wire pressure closing down over the device. And so that's where you have a risk of getting a dissection. That's ultimately been it. I think that, for restenotic lesions, which is, the money maker for this, in most AV access, certainly the bell curve lesions that you see within the circuit from the arterial inflow, wherever that may be, to the outflow, this device works beautifully. I would say that the more developed that access is, the more passes are often required to get the desired result. So typically in a well-established access that is very well arterialized, we'll do 4 passes without a hesitation. If you're in a new AV access and you're looking for, hey, I've got this stenotic lesion, we're early in the cannulation cycle and that lesion is quite tight, I'm a little bit more judicious and will do one pass and then shoot a little bit of contrast to see if we have any luminal gain, 2 passes, etc. And then just a little bit to be sure that we have it under luminal gain, or evaluate it with ultrasound to make sure that you don't have any extravasation or blush outside or hematoma outside the vessel. Short of that, no, I'm guns ablazes with use of this access. I'll use it in declots. You can use it in grafts, use it in stent stenosis. I mean, that's the thing about the power of this device, is that it was designed and they've studied it in real world populations. They're looking at all comers. They were not specific. And, it's sort of a gutsy thing to do for a device company, is to say, hey, we've got a problem that we're trying to solve, and we want you to really put it through its paces. We want you to put us in a situation to make it fail. And, and I think that's what's really extremely admirable about how they've done this. And it's really quite nice about what they've done, because really all we've seen is a reduction in the radial tension when we do the balloon and angioplasty, and a reduction in your typical elastic recoil, because you've treated those collagen microfibrils. We've broken those down, that intimal hyperplasia, and it's been incredible. So from that regard, hats off to the company, and nothing specific about caveats other than very tight acute turns, like any device, like a stent or anything that's on a trigger mechanism. It's tough to get the mechanism in and out also.
Yeah, fussy. All right. So the question that I want to ask, and it kind of gets to the data, is, Omar, we can start with you. In your mind, is the data there that the Flex device improves primary patency of fistulas after?
I think it is. If you look at the Flex, and I think Ari said he's going to include links to the paper.
Yeah, we got a link to the papers. Ari's a veteran of the show.
Yeah,
he knows we'll sync them up.
Yeah, I mean, if you look at the 12-month, Flex results, right, and you compare it to some of the old existing data for target lesion primary patency, right, it's usually around 20 to 30%, right? And at the cephalic arch and the cephalic arch fistulas, or brachiocephalic fistulas, it's around 10 to 25%, right? And with the Flex, at their 12-month data, I mean, it was showing 50% target lesion primary patency, and compared to the 20 to 30, and at the cephalic arch, I think it was 60% compared to the 10 to 25% in existing studies without the Flex. And the other thing you have to look at in this study is, what I like to talk about is the inclusivity that VentureMed did when taking on this, this registry, right? They were all comers. Most devices and most device companies, when they come out with something, they cherry pick, and I'm just being honest, they cherry pick their patient population. You want healthy, semi-healthy people that are going to give you good outcomes, that make your your device look good, right?
Make the data look good, make the device
look good. You're going to give Tiger
sure.
Woods the Nike clubs and not Omar Davis, right? Because he's going to make them look good. So with this, they took all comers. They let the patient population that is at risk, that is being treated, which is predominantly African Americans, right? And where normal studies, I mean, usually the rate is anywhere from 10 to 30%, or 2 to 30% African Americans in the studies. They had, if you look at it, it was 68.5% African American and 53.5% females. This is unheard of when you're looking at device trials or even registries, right? And for the data to come out the way it did, it shows the power of this device and how good it is. I mean, they were willing, look, we know this is good. We know it's going to work. We're going to test it and bring anybody. But we want to know this, because in my center today, 70 to 80 or 85% of the patients I treated today were African American, right? And I want to know, if you bring me a device, did you test it on them, right? So the device, I can't wait until I get into my ASC setting, or I'm able to use some of these pass-through codes, because with the ease of use, the data that's coming out right now, talking to some of my peers such as Ari and Shavarian that are using this, I mean, they're loving it and they're getting great results. So I can't wait till, I get to use, I can use it in some cases, selected cases that are difficult that we need to get this patient taken care of, but I can't use it on everybody that I need to, and they deserve this product. So,
Well said.
I'm kind
that
of passionate about this because our patients need great devices and new things to help them out.
That's awesome, Omar. Ari, I felt like you were wanting to chime in. Anything to add as far as the data goes?
Well, I think Omar hit it right? If you look at the outcomes for the Flex, right, 12-month target lesion primary patency was 49% versus, 0 to 47 for PTA alone. If you look at freedom from target lesion revascularization, you're looking at 267.3 days, pretty high. Cephalic arch lesions, target lesion primary patency, 60%, Omar said it, versus 0 to 33%, depending on who you're reading and what with PTA alone. If you include grafts, we know that your freedom from target lesion reinterventions, 228.5 days versus 68 to 76 days. So if you look at that, there's a pattern here that continues to show just by adding balloon, overlying this product and vessel prep, that this is a real therapy. And if you can follow that out, John Ross, as I mentioned, he did something called the AVIFLEX study, which is a prospective single-arm trial at his DAC. And 6-month primary patency, he got Flex plus DCB up to 84%. And with DCB alone was only 71%. And with plain balloon angioplasty was 63%. Right, so the real world experience is continued on. Robert, I think, has done a great job, and he's got some published work that's going to be coming out, I think, in 25 or early 26, and I bet you it's 25, knowing Robert Shavarian. So, great stuff. And when we talk to, interventionalists who are in the space, it's the least kept best secret in the world. As soon as someone works with a device and has real experience and their outcomes are valued and the authenticity of what they're speaking about is corroborated, and then they try those results, they try those products, the story that we've been getting has been quite similar. I had a friend of mine, recently up in the Staten Island area, and he was doing a case and measuring flow volumes and just simply using the device, did plain balloon angioplasty, they measured a flow. He did it opposite. Would do plain balloon angioplasty, got the flow, it was, let's try the Flex. Did the Flex, plain balloon angioplasty. Same lesion, flow doubled.
Really?
So
that's pretty telling. I mean, that's pretty cool. I haven't heard that.
It's an anecdote, right?
Sure.
I mean, that's an anecdote.
Part of the story, but still.
Part of the story. And I think that's what's really great to see is understanding where you apply these technologies, how you apply these technologies, and you start to find a nuance on where you're going to get optimized results. Overall, overarching, in every single territory within the AV access circuit, you're going to improve plain balloon angioplasty with the addition of a Flex vessel prep prior to that balloon angioplasty. Keeping in mind what Omar said is right. It's protracted balloon angioplasty.
Okay. All right. Well said. We'll have to link also to old episodes. That was a focus of some of the prior episodes. But
right.
Just so Ham at home, put a finer point on it. So, Omar, protracted balloon angioplasty, because I think there are a lot of people that still go up and down real quick. They pop a lesion and then bring it down. Can you kind of talk about why you keep it up for 2 minutes? Or
So
oh, look, you sighed. It's almost like you're rookie mistake. I mean, how do you feel about it?
Well, I have to give credit to so I'm an interventional nephrologist, but I treat a wide variety of diseases in my patients. I treat what ails them and their ailments, and PAD is one of the things. I was able to go train with a cardiologist for over a year to learn how to do peripheral arterial disease cases on these patients that are having wounds and amputations. And that was the space and where I learned that they do this protracted, 2 to 3 minute balloon holds to help with scaffolding and keeping the vessel open. it's not even isolated to the arterial space. Central venous stenosis, I think, is where we really did it in the AV access, 3-minute to 5-minute balloon holes on central vessel stenosis in the innominate and subclavian veins and superior vena cava. I mean, I do it. My partner, I giggle at my partner because she's like impatient. So she likes to go up and kind of come down. And, we just turn on a little bit of good music and inflate the balloon. And I have my tech just, hey, keep holding, keep pressing on that balloon. But I have found that I see less dissection, and this again anecdotal, like I see less dissections when the balloon comes down, less perforations, and it's not going to hurt. It's not going to hurt. The only thing you have to watch out for is grafts or patients that are, are prone to clotting. I usually give them maybe 2,000 to 3,000 units of heparin in the cases I know I'm going to do some prolonged inflations. And, I tailor it. It's usually fistula, hardly ever grafts, so I may be 1 minute on this patient, 2 minutes on this one. Oh, this lesion's bad. Let's go 3. But again, I don't get to use I'm not using the vessel flex device like Ari is able to. And some of those algorithms may change when I start using those devices.
All right, we're coming up on the hour. I'll leave it open-ended. Final thoughts? It can either be about vessel prep, dialysis access, or anything else. Open mic. Omar.
I don't know. I would like to we have a gentleman out and give a shout out to Fred.
Please do.
Fred Hill is a patient, Ari may mention him too, that now he's got a transplant, but he was a dialysis patient. And I like to point out mental health anytime I can, because one of my patients was suffering from severe depression. He had stage 4 liver cancer. He's on dialysis, and he told me, I just feel like I don't have anything left. I don't know why I'm here. And sometimes we get caught up in doing our devices and our work that we forget about mental health of patients and everybody. So Fred Hill's got a book and a class that, dialysis is not your life.
Your life.
And he's basically saying that he's giving patients that power and that positive motivation to regain their individuality and who they were, that they lose often when they start dialysis. And it's a program that you go through. You can check him out. We'll leave links. But one of my patients went through that program. And it's kind of odd, and I promise I did not plan this, but he came to see me today, that patient who went through Fred.
Come on.
I promise you.
Universe talking to you.
All right, I like it.
Is Alan Curry. He will let me say his name. He is a wonderful patient. He has stage 4 liver cancer. He's on dialysis. He has a percutaneous fistula. And you would think that he just won the lottery every day you see him. And he says he really thanks Fred for going through that program. It did help him to talk to somebody who had the disease he had. I can say it all I want, but I don't have it. I didn't have it. I don't have ESRD. But both of them went through it. And so I just really want people to think about their patients and their mental health. And remember, it's always a person behind that. It's somebody's grandma, somebody's grandfather, somebody's brother, somebody's child, brother or sister that we're treating. And that's in every aspect and every arena of healthcare. So just be cognizant of that. And if you have a patient, dialysis patient that is, just talk to them and maybe kind of send them that way to check out what Fred's talking about.
Man, that's super well said, Omar. I can't. I mean, a lot of this podcast, the audience is a bunch of gearheads, people who love to geek out about interventional nephrology or vascular access or whatever. And sometimes you can get a little bit lost in the procedure and forget about the patient. So thanks for bringing that up, Ari. Did you want to draw attention to the foreword of that book?
Yeah, you know what? I will. I wasn't going to. So Fred was a patient of mine, and he texted me, called me at the office, and said that he had written a book and he was leaving this for me on my desk. And I kind of really touch on it in that forward, that book sat on my desk probably close to 6 months before I opened it, because I didn't quite know how to break down the boundary of me as the provider. We do quite a lot of separating ourselves mentally to separate the challenges that our patients face. And it's rightfully so in some ways, because you have to stay objective about the things that you're doing. But on the other hand, when I did take the opportunity to read that book, really gave me insight not only into Fred, but it gave me insight into my own humanity. It's something that I read, honestly, without being on dialysis, because it's very plain spoken, and it talks about, what it is, whatever the thing may be, that you have a loss of autonomy and you're really facing these dark places in life and how to overcome these challenges. And the natural, honest experiences of a man who was going through that, who put it into words to share that experience. He's a pastor, and you can understand, I can't imagine how powerful it must be to hear him speak, because what he did is simply remarkable. Many of us have a disease, or we have a circumstance and we just suffer in it, or we rage against it. He was activated by it, and not only activated by it, he was motivated, and in his mind, through the word, through God and through his faith, being able to share this journey as a blessing to him, to find strength, to share this journey with other people. And it's honestly one of the most incredible books I've ever read. And it motivated me. I was honored he asked me to write the foreword to the book. And I can tell you that every person who has met Fred, who is now himself on an international audience, is incredibly moved by meeting him, his sincerity, his energy. It's an amazing thing. You'll find yourself really asking yourself some challenging questions. And mostly it's like, how am I complaining, and why am I not doing more? Right? Like, it's mostly that.
Sure.
It's mostly that. So I can't encourage anyone enough to look at Fred Hill, and dialysis is not your life. But you could put that as anything is not your life if you're struggling with anything. It's an incredible journey.
All right. Super well said. Ari, you want to share some cases?
So just, I think it's nice before we get into this is visual of the device, okay? And this is the configuration that it comes in. You can see exactly what we talked about, the kinetic microincision creation, and you can see those struts with the microblades on the back end of those struts, and with the back, how you're pulling it back to re-sleeve the device, okay? So self-sizing, etc. And when you look at the mechanism of action, these are actual images that you can see that circumferential engagement. You can see the release of what happens with that device into the stenoses, whether it be fistula graft or in-stent stenosis. And you can understand now, if you want to couple this with drug-coated balloon, and we didn't really mention it, but some people are moving, because you can get that opening pressure to effacement at somewhere between 10 to 12 atmospheres, and most of the drug-coated balloons are rated to about 16 atmospheres of pressure. They're obviating that second balloon, and if they're using a drug-coated balloon, they're going from flex to the drug-coated balloon right. So just as a side note, unstudied completely, by the way. So here's a recurrent cephalic arch stenosis, a patient that we've seen, and is coming in. This is their 6-month follow-up. They had a high-pressure outflow stenosis, and all we could find in the circuit was this image. And it's fairly characteristic, where you get this little bit of bird beaking, you get a little bit of what appears to be some valvular disturbances up closer to the humerus. And then if we move forward, this is actually the use of the device. So the 014 wire is advanced, and you can see how that is pulled back slowly. And you can see how the device is conforming to those stenoses. You re-sleeve it. Okay, we advance back in. Again, we go as far as that juxta segment with that central system, and we'll re-sleeve and pull it back again through, and we're rotating that device 90 degrees each time. Okay, and so that's just a real time of what we're choosing to do.
And the nice thing is, you can feel the resistance as it's coming across kind of a lesion. It's kind of a satisfying feeling, right? Like you want to drive back and just keep coming across.
You're exactly right. And then the follow-up, which we do, is just to make sure that we don't have dissection, etc., is we can see that's the luminal gain that we got from just the device. So there's no balloon deployment. We went ahead in this instance. This is, I think, 150 centimeter 150 Mustang balloon. So we brought that up to profile, and that's at 16 atmospheres of pressure, and we had profile at 10 to 12 atmospheres of pressure across all of that. Now, because it was a recurrent lesion, and because I wanted to speak to a little bit about the data that we were seeing after that, we repeat our intervention. That was a protracted balloon angioplasty. In that instance, it was 120 seconds. Thank you, Omar, for the exact countdown.
There you go.
And we told a couple of jokes. We didn't listen to the radio. Actually, we did both. So, and this is the follow-up on that angiogram. Now, because of the length of that lesion, we had a lesion that was here. We had one that was sort of scattered in here, and then we had that outflow at the distal extremis of the cephalic arch. We went ahead and actually onlayed 2 drug-coated balloons. So that was the first. That was the second. Each of those with 180 seconds worth of balloon hold at nominal. And then we got our final result. And I think, everyone would be quite pleased, that we'll feel comfortable saying that we'll get very good, durable results. So that was really the case. These are the peer-reviewed publications that have been presented thus far. There's the 6-month and 12-month cohort analysis, as we talked about. And then there's Omar right there. Third is right. So there he is. And then there's some additional stuff that's been presented that we talked about. John Ross's stuff, in showing real typical results. And what you can see here is pretty significant results. And you can see when he's looking at these various sources and you're looking at outcomes, how he's comparing these outcomes and how favorable they start to become by adding this device to it, and the why, right? So I think that it's very meaningful, particularly when you start looking at these Kaplan-Meier's out at 210 days and seeing what, for example, what the Lutonix IDE showed at 6 months versus the onlay is entirely different. And I'll send you this whole PowerPoint. You can show with it as you would like, what you would like, with the summary data. And there's John Rooney, who was the lead author in this. And then Robert, also a tremendous job with his studies and showing his technical success. Now, what's interesting about Robert is that they're doing this completely under ultrasound, by the way.
Yeah.
And
really? No angioplasty at all? Wow.
No fluoro.
Oh, sorry. That's what I meant to say. No fistulogram, like no fluoro. Yep.
Yeah, no fluoro. So this whole experience, is, kind of an illuminating experience, right? So you can see 42% juxta anastomotic, you have 100% technical success. And what we're talking about with that PTA, you're at that 10 to 12 atmospheres, in their mean was 13.8. So, and he's doing 33% of his without plain balloon angioplasty when he's doing drug-coated balloons. So really remarkable. And when you look at the numbers to treat, and that the reintervention rate of 0.2 to maintain access circuit patency is really quite extraordinary. And he's highlighted some, I think, very powerful findings. And you can see, if you look at this Kaplan-Meier, it's extraordinary. And I believe this is what's going to be coming out. You're at 481 days, and you can look at that Kaplan-Meier running out. It's pretty extraordinary. So when you compare these studies, and they're over and over, you're seeing a significant enhancement over plain balloon angioplasty. Even when you're comparing his data point here to IMPACT, which was outstanding by itself, we would have been happy to have 86.1%, but his interpolating his data with the onlay flex plus his DCB is at 95% at the same mark. It's pretty impressive. And Robert's quite a scholar, so really good. And then just those studies that we shared. So that's my wrap up on my side. I hope you guys found it informative. I certainly, have really found a home for this device in our practice, and we think it's really a new standard of care for how we do most balloon angioplasties, and really enhancing the patient experience, really being respectful to the healthcare dollars, and getting a very controlled outcome that is safe and effective and durable. I think it hits all the right marks for what we're looking for technology to do.
Nice. All right, guys, I think that I think that's a pretty fine point on it. Omar, anything to add? I didn't mean to cut you off.
No. Ditto on that. That's right. I mean, we need things that are going to work and the ease of use so that we can spread them amongst a variety of different users, right? Like that's key. That is very important that people tend to stray away from devices that are difficult to use. And this is not even close. It's very easy, simple to use.
So that wraps things up. We'll see you next time on the BackTable podcast. Ari, Omar, the champs.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at @_BackTable on Instagram, Twitter, or LinkedIn. BackTable is produced and hosted by myself, Aaron Fritz, and co-hosts
Chris Beck,
Sabine Dawn,
Michael Barraza,
and Ali Behetti.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles,
Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang,
Manisha Naganathanahali,
and Manbir Singh Sandhu.
Administrative support provided by Jamila Kennebrew
and Judy Dela Cruz.
Thanks again for listening.